Hi everyone, my name is Dr. Ahmed Azigid. I'm one of the physicians here at North Cyprus IVF Center, and today I will talk to you about IVF treatments in general. We're going to talk a little bit about infertility. We're going to talk about how treatments are performed specifically here at North Cyprus IVF Center. This is just an overview of the presentation today. We're going to do a little bit of introduction. We're going to talk about the procedure and the timeline of treatment, especially if you're traveling from abroad. How does it work? How do you do the initial testing, and so on and so forth. Okay, so in terms of defining infertility, we do have the textbook definition of trying to conceive continuously with natural intercourse for about a year. So without the use of any contraception, you've been trying to conceive for about a year through regular intercourse, but you have not been able to fall pregnant or carry a pregnancy to term. So either way, infertility doesn't only refer to not being able to get pregnant. It also refers to not being able to carry to a full term. So essentially, if you are in your 20s or maybe even early 30s, then you do have a bit of time. You can try naturally for a couple of years and then take it from there. If it doesn't work, then testing can begin, can be initiated. But if you're above the age of 35, getting in, like closing into your 40s, then maybe waiting is not a very good option, because with each passing month, your fertility level will further decline. So it kind of depends on what your existing fertility level is, so that infertility can be defined slightly differently for different people in a way, in terms of the time frame. There are two main categories of infertility. One of them is primary and the second one is secondary. What we mean by primary infertility is if you've never been pregnant or if you've never carried a pregnancy to a full term in your life, then you would belong in the primary infertility group. Secondary infertility refers to people who have been pregnant before or who have conceived before naturally without any assistance, but now cannot conceive anymore. This is probably maybe you've conceived in your 20s or early 30s, and then now you're in your late 30s or early 40s and you're no longer able to fall pregnant. So this is usually refers to people who had a child before but now cannot conceive for any reason, and most likely this is due to age. So there is this stereotype that whenever there is an infertility problem, people view it as female predominant. This is not the case. Both males and females suffer from infertility equally. And it's quite important that both males and females undergo infertility screening whenever they have an issue with conception. What we do, the way we design our protocols is, because most of our patients come from abroad, because they come from abroad, it may not be convenient for them to stay in Cyprus for a prolonged period of time. So what we can do is we can design our treatment protocols so that you can get your initial testing, initial scans, and you can start using your medication locally in your home country, and you can come to Cyprus for about 1 week to finalize your treatment. Alternatively, if you would like to start and finish everything here without having to go through local testing or local screening, if it's more difficult, if it's more expensive to get the medication locally, then the alternative is, if you do have the time, if you can spare 3 weeks of your time, then you can come to Cyprus for an entire 3-week period where we can start and finish the entire treatment here. So the way this works is the procedure itself, an IVF procedure itself, refers to combining the sperm sample from the male patient with the egg cells from the female patient in the laboratory environment. This is because natural conception doesn't occur when you engage in intercourse. So what we do is we get the sperm sample, we get the egg cells, and we combine them in the lab. And this treatment could be sought after because you've been trying to conceive naturally for years and it hasn't happened, or maybe you've had IVF cycles, you've had repeated IVF failures back to back, and then you're trying again. So depending on why you're seeking treatment or how many treatments you've done before, the testing requirements are likely to differ. So if you are a patient who's never had a treatment before and you're looking into getting treatment, then we would ideally start with the initial fertility testing. The initial fertility testing is usually a good way to establish a baseline for your natural fertility levels, and then that can give us a pretty good idea of how to proceed with treatments. However, if you've had testing before, and if you've had treatment cycles before and they haven't worked, and you're having a difficult time conceiving not just naturally but also with IVF cycles, then it's probably about time to undergo an advanced fertility testing. So depending on what seems to be the issue, depending on what kind of issues you're having during your IVF cycles, advanced fertility testing can give us more information. Once we get through these initial fertility testings, then it's time to design your protocol and start using medication. After your medication usage comes the actual IVF cycle. And then once we finish the IVF cycle, once we collect the eggs and fertilize the eggs with the sperm sample, then we can plan your embryo transfer. So in terms of the initial testing, this is the required minimum testing for every single patient who's going to undergo an IVF cycle. This helps us make an effective assessment of both the male and the female patient's fertility levels. And this assessment helps us design a customized protocol for each and every patient, because essentially age-wise, you can be the same age as another patient, but biologically, in terms of your ovarian activity, in terms of your hormone levels, each and every patient is going to be different. So one prescription does not fit all. Therefore, we need to make a unique treatment protocol for every single patient. So what kind of testing does a female undergo? Ideally, for the initial testing, for the basic testing, the minimum standard of testing before an IVF cycle, we will ask for a baseline pelvic ultrasound scan. Baseline means that we want this scan to be performed at the beginning of your menstrual cycle. Ideally, day 2 or 3 of your menstrual cycle, while you're still bleeding, is when the pelvic ultrasound scan needs to be performed. The reason for this is your follicles will be at their smallest formation at this time of the cycle. So we will be able to see your preantral follicles during this time, and we will be able to decide on a medication protocol that will give us the optimal number of eggs after the IVF cycle. So on the same day, on the very same day as your pelvic ultrasound scan, we are likely to ask for your FSH, LH, AMH levels as well. These are the follicle stimulation hormone, luteinizing hormone, and anti-Mullerian hormones. These hormones will give us a pretty good idea about your ovarian activity. At the same time, your prolactin level, your estradiol level, and your TSH level will give us a pretty good idea about the other hormones that are secreted from the pituitary gland, from the same gland that makes the FSH and the LH, because sometimes these hormones can interfere with each other. So if there's a problem with the other hormones that are being secreted from the pituitary gland from your brain, there is a good chance that they are affecting your fertility as well. So this is essentially a precautionary testing just to see if there is any other problem. FSH and LH levels, they do indicate your follicular growth and ovulation potential, and these are stimulated from your pituitary gland. These are secreted from your pituitary gland in your brain. So they do work with a feedback mechanism. So if your FSH and LH levels are, say, very high, then your brain thinks that it needs to secrete more and more FSH and LH. This is essentially why your FSH and LH levels are quite high, because your brain thinks there isn't enough follicular development, there isn't enough follicles undergoing ovulation, so it keeps secreting more and more and more. The reason for this is because your ovaries are probably very underactive. So the higher your FSH and LH levels are, the lower the level of your ovarian activity. So there is that feedback mechanism there. AMH, on the other hand, is secreted directly from the ovarian follicles, the surrounding cells, the cumulus cells that surround the ovarian follicles. So it is more of an accurate picture of your ovarian activity at that specific point in time, and it doesn't work with a feedback mechanism. So it does reflect that exact period of time that is measured. In terms of male testing, it's not as extensive as female testing. It's just a semen analysis. So essentially the very first test that we ask for the male patients would be a semen analysis, so that we can assess certain parameters of the semen sample, such as volume, concentration, motility, morphology, the round cell count, the pH, and so on and so forth. These parameters of the semen sample will give us a pretty good idea of the semen's capacity to undergo the conditions of the female reproductive tract and fertilize the eggs that are in the fallopian tubes. So if there's a problem with the semen parameters, then we would look into further tests. But this is usually the very first test that we would administer on the male patients. Now, in terms of advanced testing, it is quite difficult to talk about which tests we would require from which patient, because again, each patient is different. Each patient undergoes a different scenario, different problem. You may have had IVF cycles repeatedly and they may have all failed, or maybe your IVF cycles don't fail. You are able to get pregnant, but you do miscarry in the early terms or in later terms. So depending on what kind of issues we're dealing with, maybe you do produce very good quality eggs, maybe you do not produce very good quality eggs, maybe the semen sample is problematic. So it just depends on what kind of issues you're dealing with during your IVF cycle. So based on these, we would be able to decide what kind of additional testing we would require from you. Just to name a few of these tests, a genetic karyotyping might be one of them. We might test your immune system. Maybe you do have an overactive immune system that's attacking the embryo, and it's causing you to miscarry. Thrombophilia defects could induce blood clotting issues, and the baby in your uterus, it might get a blood clot in its circulatory system, and its heart may stop. So this might be another problem you might be having during the pregnancy. Infective agents are usually a cause of miscarriage, but they don't necessarily cause recurrent miscarriages after the active phase. So even though it was thought that they would be causing repeated miscarriages, it is no longer believed so. Hormonal factors, your hormonal activity, uterine conditions, whether the uterus is able to carry a pregnancy, or maybe you might have a polyp, you might have fibroids that might interfere with a pregnancy. So these would need to be investigated. So after you have your testing done, after you get your test results, we would be able to design your treatment protocol. So once we have your test results, once we have everything that we need, we would be able to sit down, revise those documents, and design a treatment protocol that is likely to optimize your IVF cycle outcome. So in order to maximize your level of success, we would design a suitable treatment regimen for you. So once we design the treatment protocol, this treatment protocol would include some use of medication. So this medication you would start using with your cycle, with your menstrual cycle. Depending on which protocol we would use, we would inform you when to begin using the medication. So you would start using your medication, and the reason for using medication during an IVF cycle is to produce multiple follicles so that we can get multiple good quality oocytes, multiple good quality eggs. Having multiple eggs will give us the opportunity to end up with multiple good quality embryos. Having multiple embryos gives us the possibility to choose the best embryo or embryos for embryo transfer, so that we can increase your chance of success and perhaps have more embryos to perhaps freeze, so that if your initial IVF cycle fails, you have more embryos to fall back on for a future cycle. Or even if you do have a pregnancy initially with your first IVF cycle, you may want to keep more embryos for a future sibling project, so you don't have to go through the same IVF cycle again. So this slide gives us some information about different treatment protocols for different patients and what we take into consideration. We take into consideration the female patient's age, the AMH level, the FSH, LH levels as well, the antral follicle level. This is given to us by the ultrasound scan that we would ask for during the initial few days of your menstrual cycle. And if you have undergone previous cycles, previous treatments, then we would like to see those as well, the details of these cycles as well, because we would like to see how much medication you used, what dosage of medication, what type of medication regimen you used, and how many good quality eggs this medication usage resulted in. So it can give us an idea of how your ovaries are likely to respond to certain medication, certain level of medication, so that we can adjust things accordingly. So having a negative cycle is not necessarily a bad thing when it comes to IVF cycles, because it can actually give us plenty of information about how your ovaries are responding to medication, how many oocytes, how many eggs you're able to produce in a given cycle, so that we can modify and design things accordingly. There are two different types of medication protocols when it comes to IVF cycles, two broad categories, let's call them. One of them is the agonist protocol, and one of them is the antagonist protocol. The agonist protocol is usually something that is preferred for patients in younger age brackets. It uses an initial down regulation. So it suppresses your own hormones, it suppresses your own ovulation, so that the physician can have a larger amount of control over your menstrual cycle or over your ovarian cycle, so the medication administered externally does its job. But because it has the potential to shut down your own hormones, if you do suffer from a low ovarian activity, if your ovarian function has been declined, then using down regulation initially can suppress your hormones too much, and you may not respond optimally to the IVF cycle. So in patients in older age brackets or patients with lower ovarian activity, we do prefer to have no downregulation. So we do prefer option B, which is the antagonist protocol, which gives us a better control over the very few follicles that you might have. So it just depends on your AMH level, FSH level, LH level, in other words, your ovarian activity and your age, which type of protocol would be more suitable for you. If you suffer from polycystic ovaries, so if you have PCOS, polycystic ovarian syndrome, then using the agonist control, using the agonist protocol could potentially induce ovarian hyperstimulation syndrome. So with PCOS patients, we avoid the agonist protocol and we opt for the antagonist protocol instead, so we don't receive an excessive amount of ovarian stimulation, which could jeopardize your own health. So we've done the testing, we've designed your treatment protocol, and you've used the medication. Next, it's time to perform the IVF treatment. Your medication phase is about 10 to 12 days if you're using the antagonist protocol. If you're using the agonist protocol, which is the longer protocol with initial downregulation, it takes about 3 weeks. So from the time you start your medication to the time until your egg retrieval is performed is about 2 to 3 weeks, depending on which protocol you're using. Once your eggs are mature enough, once your eggs are ready for collection, you will be given a trigger shot so that the eggs go through their final meiosis, they go through their final development path, and they are ready to be collected. So this trigger injection is given to patients who are almost ready to undergo the egg retrieval procedure. After the trigger injection, you are likely to have your egg retrieval or oocyte pickup procedure in about 35 to 36 hours. So we would like, if you are traveling for your treatment to our IVF unit in Cyprus, we would like to administer the trigger injection here once you arrive in Cyprus, because exactly after 35 or 36 hours after your trigger injection, we have to proceed with the oocyte pickup, or otherwise the oocytes will die, will no longer be viable. So if you administer the trigger injection locally in your home country and for some reason your flight gets delayed, you're not here on time, it would be taking on too much of a risk. So we ideally would like to have you here, see you before the egg retrieval procedure, administer your trigger injection, and schedule your egg retrieval procedure accordingly. And obviously before the egg retrieval procedure, because it is done under sedation, we would like you to be on a fasting state for at least 8 hours. So if your egg retrieval is scheduled in the morning, then we would ask you stop eating or drinking at around midnight the day before. So once the female patient is ready to undergo the egg retrieval procedure, we ask the male patient to produce his sperm sample at the same time. This is done through manual stimulation, so through masturbation. And for optimal semen parameters, we want 2 to 4 days of abstinence. So before you provide your sperm sample, you need to make sure that you refrain from any sexual intercourse, any stimulation for 2 to 4 days. Shorter or longer abstinence periods can compromise the semen parameters. So it is not, the more is not better in this case. Sometimes patients think, oh, if I can, abstain for longer periods of time, there will be more sperm sample, higher quality. That is not the case. 2 to 4 days of abstinence is the optimal time for before you produce your semen sample. Shorter or longer periods are not desired. Shorter periods could negatively affect your semen count. Longer periods could negatively affect your motility and morphology numbers. So 2 to 4 days should be your aim when you're producing your sample. Here is a side note. If you do have abnormal morphology levels, so if your sperm samples suffer from very, very low level of normal morphological forms, then there's a very good chance that the semen sample suffers from DNA fragmentation. DNA fragmentation or DNA damage in a sperm sample is positively correlated with abnormal morphological parameters. So in such cases, what we recommend to our patients is magnetic activated sperm cell sortings, or abbreviated as MACS. And this helps us select the best sperm cells for using at ICSI. Okay, so once the eggs have been collected, once the sperm cell has been collected, we combine these cells with a procedure called ICSI. ICSI is short for intracytoplasmic sperm injection. So the best sperm cells are selected under the microscope, hand selected by the embryologist, and they are used to inject into every single one of the oocytes, the eggs. So we don't let nature take its course. We do fertilize each and every single egg one by one using the best sperm cells according to their morphological parameters. So after an egg has been fertilized with the sperm cells, then they form a new structure called a zygote. These are incubated in an incubator in a laboratory environment, providing them with a environment very close to what they would have in the womb, in the uterus. So we incubate them for about 3 to 5 days, depending on the preference of the patient, depending on the number of embryos we're able to obtain. So it kind of has a decision tree when it comes to on what day the embryos should be transferred, and that's something that we could discuss together. So after about 3 to 5 days of incubation, we would be able to identify the best performing embryos for transfer. If you do have multiple embryos, then we could decide which ones to transfer and which ones to freeze so that you can use them again in the future. So we have fertilized the eggs with the sperm sample, we have created the embryos, we have incubated them, now it's time to transfer them. And we have selected the best embryos to transfer. When does this take place? This takes place between the days of 18 and 21 of your menstrual cycle. The reason for this is natural conception, when it takes place around day 16 or 17, and around day 18 the embryo makes its way into the uterus. Around day 21, around day 20, it takes its position on the endometrium and starts attaching itself to the endometrial layer. So what we're trying to do here is we're trying to mimic what happens physiologically in a natural pregnancy, and we're using the locations of these natural occurrences so we can get as close to natural occurrences as possible when it comes to reproduction. Okay, so one thing that is done before the embryo transfer is progesterone testing. Progesterone is a very important hormone to maintain the endometrial layer, to maintain the thickness of the endometrium, so that the embryo can attach itself to the endometrial layer and obtain sufficient amount of nourishment. So in order to maintain an ideal level of endometrial layer, an ideal thickness of an endometrial layer, then what we would like to do is make sure that your progesterone level is in check. If your progesterone level is insufficient, if it's lower than the required levels, then we would supplement you with additional progesterone before the embryo transfer. The embryo transfer itself does not require sedation. It is a very brief procedure. You do not need to be under for this procedure, and on this day we would be able to give you a document which underlines the things that you should do and things that you should avoid doing, so that the pregnancy process can be less problematic. Okay, let's talk about the timeline. In terms of the timeline of treatment, as we have kind of discussed throughout this presentation, initial testing for the male and female patient is planned initially. Then, once we get the test results, we start planning your treatment. Your initial treatment can be done locally in your own country or here in Cyprus. The medication usage takes about 2 to 3 weeks depending on what kind of a protocol you're using. So if you have the time to spare, if you have the time of vacation, if you can take 3-4 weeks off your work, then come to Cyprus for a 3-week period. We can start and finish your treatment here, so you don't have to undergo local testing, you don't have to use your medication locally. But if you do have your time constraints, if you have a hectic schedule and you can only travel to Cyprus for about a week, then this can be arranged as well through satellite monitoring, through the use of medication locally. And once you arrive here, the first day we would offer you your consult and final scans and tests, and then we would proceed with the oocyte collection and obtain the sperm sample, perform the laboratory processes, and proceed with embryo transfer accordingly. So this is our team that you will get to meet once you're here in Cyprus. Okay, so thank you very much. I hope this was useful. I hope you do get some benefits from this video.